Welcome to the Continuous Positive Airway Pressure Transition class. The term continuous positive airway pressure was coined in 1971 to describe an elevated airway pressure therapy for spontaneously breathing, intubated neonates. The current application has expanded to include adults and more recently patients without an artificial airway. CPAP is the application of positive airway pressure throughout the whole respiratory cycle to spontaneously breathing patients. We will be going over the goal of CPAP in the field, the physiological effects, how it's delivered, the medical applications, and when not to use CPAP. The goal of CPAP is to help prevent the need for mechanical ventilation and intubation by delivering positive end expiratory pressure, or PEEP, while decreasing the incidence of barotrauma and volutrauma. It also helps EMS provider avoid complications from intubation-related sedation or paralysis, in addition to such unexpected difficulties as hypoxia, lethal dysrhythmias, tissue trauma, aspiration, and undetected esophageal intubation. This slide shows the history of CPAP. It was initially used all the way back in 1912 and used throughout the 60s and 70s to treat acute respiratory failure and COPD. While its modern use with a mask has occurred since 1982, it really wasn't introduced into EMS until the early 2000s. Some agencies today still don't utilize CPAP. This slide illustrates simulated breath traces at atmospheric pressure, indicated on the slide as 0 centimeters of water, and at 5 centimeters of water CPAP. Note that for inhalation of air to occur when breathing without assistance, the generation of a pressure gradient is required. The pressure within the lungs is negative compared to that in the atmosphere, and air is drawn into the lungs. Then, during exhalation, the passive elastic recoil of the rib cage elevates the intrathoracic pressure to above the atmospheric level, which makes it positive and forcing air out of the lungs. The larger the drop in pressure on inhalation, i.e. the more negative it gets, the greater the patient work of breathing. When breathing with the aid of CPAP, the pressure within the lungs always remains positive. This keeps more alveoli open. We breathe in, or inspire, in order to transfer oxygen into our bloodstream, and we breathe out, or expire, to carry away the carbon dioxide. This process works because of partial pressures. The basic formula is the pressure of a gas mixture is equal to the sum of the partial pressures of its constituents. For example, air at sea level has a pressure of 760 millimeters of mercury. Air is 21% oxygen and 79% nitrogen. Therefore, the partial pressure of oxygen is 760 times 21%, which equals 159 millimeters of mercury. This is not exact as it does not take into account water vapor that is equal to 48 millimeters of mercury inside your lungs, but it's close enough to get the point across that the partial pressure of oxygen is high compared to the partial pressure of oxygen in the venous blood. A quick question. What is the partial pressure of nitrogen at sea level? The blood supply arriving at the alveoli carries deoxygenated blood. This means that the oxygen has been used as the blood has been circulated around the body. Oxygen passes from the alveolar air into the blood because the partial pressure of oxygen in the alveolar air is higher than that in the blood arriving in the lungs. It also applies the other way too. Blood arriving at the lungs has a higher partial pressure of carbon dioxide than the alveolar air. Hence, carbon dioxide leaves the blood and it's expired. Next, we have a video of how CPAP works.
Here we see lungs ventilated both with and without continuous pressure. To begin with, there is no CPAP, and you can see there is extensive atelectasis. As we apply CPAP, with each succeeding breath, you can see the lungs are becoming more and more inflated until finally full recruitment is achieved. Notice that recruitment is not instantaneous, but takes place over a period of time. After we eliminate CPAP, you can see the lungs almost immediately begin to collapse. Then, with each breath, there remains significant atelectasis. This is why leaks and loss of CPAP are detrimental to the patient. What we strive for is consistent CPAP and therefore continuous progressive recruitment of alveoli.
Our CPAP settings are at 10 centimeters of water. That increases the partial pressure of air over 1%. This increase in partial pressure forces more oxygen into the blood. Even this comparatively small change is enough to make a clinical difference. The real requirement is for continuous, constant positive airway pressure with minimal fluctuations in system pressure between inspiration and expiration. This constant pressure will help reduce the patient work of breathing, which is important since it reduces the resistance to airflow that is present in lung disease. This holds the alveoli at more inflated levels. It is easier to fill the inflated alveoli and hence less work of breathing. This can be likened to blowing up an uninflated balloon. It is hard to get the balloon started, but with each breath, the balloon gets easier to inflate as its radius gets larger. Some systems meet the basic criteria for CPAP. That is to say, the system pressure remains positive. However, due to marked swings in the level of pressure throughout the breathing cycle, and particularly at peak inspiratory flows, the effectiveness of these systems should be closely examined, since they can actually increase the work of breathing. Don't use CPAP on every patient that needs supplemental oxygen. Use nasal cannulas or masks on them as we have always done. CPAP is indicated for people who are sick. The patient may not need to be in the stabilization room, but they should have serious respiratory difficulty to need the use of CPAP. Medium concentration oxygen masks are unable to deliver an accurate oxygen percentage since the patient inspiratory flow is not taken into account. Venturi masks can deliver accurate concentrations at 24%, 28%, 35%, 40%, and 60%. However, the higher the O2 percentage, the greater the necessity is to humidify the oxygen, especially for long-term use. Humidified oxygen is able to be delivered up to 60% oxygen, but only accurate up to a peak inspiratory flow rate of 22 liters per minute. Above that, the percentage is diluted according to the patient's demand. CPAP is the only system capable of delivering 100% humidified oxygen at flow rates up to 140 liters per minute, thus satisfying all the clinical requirements. Functional residual capacity, or FRC, is the volume of air remaining in the lungs at end expiration. Lung diseases culminating in respiratory failure are commonly associated with a reduction in FRC. The beneficial effects of a distending pressure applied to the airways at end expiratory by PEEP or CPAP stem from the increase in FRC leading to an improved gas exchange. CPAP distends alveoli preventing collapse. Intrinsic PEEP or auto PEEP is usually about 5 centimeters of water. It must be overcome before negative pressure can be generated to inhale more air. If one exhales against the resistance, smaller, dependent airways are splinted open at the end of expiration, and small bronchi and alveoli don't collapse. A greater alveolar surface area improves gas exchange. As alveoli stays open, gas exchange time can double. This increases oxygen levels in the blood and decreases carbon dioxide levels, as long as the respiratory diffusion and pulmonary perfusion dynamics are working properly. This reduces hypoxia and reverses hypercarbic ventilatory failure. Greater saturations are possible without increasing the pulse ox. In a study in which CPAP was given to fit athletes in 1979, the study reported that, in all subjects, FRC increased proportionally with the level of CPAP administered. This was accompanied by a 45% reduction in their inspiratory work of breathing. The positive pressure from CPAP increases the volume of air left in the lungs at the end of expiration, which increases the functional residual capacity. As a result of the increase in FRC, additional areas of lung are recruited into the gas exchange process and allows for an improvement in blood gas values. Since CPAP shifts the lung volume along the compliance curve, it reduces the patient's work of breathing. In addition, as more alveoli now participate in the gas exchange process, the VQ mismatch is corrected and the fraction of shunt is reduced. CPAP changes the alveolar hydrostatic pressure dynamics. An increase in alveolar pressures will counterbalance interstitial or capillary hydrostatic pressures and will slow or stop movement of fluid into the alveoli. Positive airway pressure pushes fluid out of the alveoli in pulmonary edema and will stop further influx. Here are the essential components to a CPAP system. The flow generator should ideally be able to provide flows to exceed all possible PFERs and be able to do so at the required oxygen percentage. The resistor, either set at a specific threshold levels or adjustable to a required level, will provide a resistance to the flow through the circuit, allowing the pressure to elevate within the whole respiratory tract up to the prescribed level. The circuit pressure will be maintained at this threshold level only if the valve remains open. This is only achieved by ensuring flow constantly passes through the valve. Ideally, the valve should be flow independent and thus prevent large swings in the circuit pressure from the intended level. CPAP delivery is affected by the quality of these two components. The goal is to deliver CPAP without circuit pressure changes. The CPAP valve is a disposable valve with a 22 millimeter inlet and outlet connections. It is set at one pressure rating, 10 centimeters of water. When choosing the mode of patient connection, always ensure it's the most appropriate, and that if it's applicable, the correct size is also chosen. For example, due to the necessity of a good seal when using a mask, the correct sizing of the mask is particularly important. Many patients complain of discomfort experienced with some of the inflatable full-face masks. This can be for a number of reasons. It is painful on the bridge of the nose. Air leaks into the eyes. The straps block the vision, etc., etc. Poor patient compliance will inevitably result, which could also have been avoided by careful consideration first of the patient and their condition. Many various sizes of rib cushion face masks are available from manufacturers designed to suit individual patient needs and hence improve patient comfort. In order to maintain circuit pressure, it is important to keep the CPAP valve open. Therefore, there will always be some flow through the valve even during patient inspiration. This can be verified by examining the valve disc during inspiration or by placing a hand over the valve exhaust port to ensure that there is flow during both breath phases. Peak flow rates will reduce after a short time on CPAP. The flow through the circuit should be adjusted after the patient stabilizes so that 1. Oxygen waste is minimized, and 2. Noise generated is kept to a minimum. Here is the complete CPAP system with an inline nebulizer. Regulator-based, portable, non-invasive positive pressure ventilation systems generate continuous pressure from oxygen flow, directly controlling inspiratory and expiratory pressures. Regulator-based, non-invasive positive pressure ventilation systems allow different inhaled oxygen fractions, reducing oxygen consumption. At 10 centimeters of water pressure and 100% inspired oxygen at a flow rate of 15 liters per minute, a size D oxygen cylinder will last between 20 and 30 minutes. At 65% inspired oxygen, a size D oxygen cylinder may last up to approximately 35 minutes. Regulator-based systems are often compatible with end-tidal capnography and inline medication nebulizers. Here's the CPAP setup on a portable O2 cylinder. The flow meter was added so that pre-hospital personnel could easily remove the CPAP with a quick connect instead of threading and unthreading the unit onto O2 connections. When applying CPAP to a patient, have 3 straps already cinched down to an expected degree of tightness for a typical head size. Attach the 4th strap and Velcro it tight to create a tight-fitting mask to maintain CPAP pressure inside the mask. Here, the 4th strap is cinched tight. HEM CPAPs have Velcro fasteners rather than buttonholes. CPAP is used in both pre-hospital and hospital environments. CPAP has been successfully shown to treat the following medical conditions: acute respiratory distress syndrome, or ARDS, is a common and devastating condition which can affect all adult patients. It occurs when non-cardiogenic pulmonary edema, secondary to acute damage to the alveoli, leads to an acute respiratory failure. In early ARDS, continuous positive airway pressure with 40 to 60% oxygen may be adequate to maintain oxygenation. ARDS characteristics include hypoxemia, reduced compliance, and a large intrapulmonary shunt. The shunt is due to deoxygenated blood flowing past alveoli that are not functioning well, so the blood is not oxygenated in the lungs and is returned to the left heart to be pumped to the body with low oxygen. CPAP in the early stages may correct hypoxemia, improve compliance, and reduce the intrapulmonary shunt. Cardiogenic pulmonary edema is defined as pulmonary edema due to increased capillary hydrostatic pressures secondary to elevated pulmonary venous pressure. Pulmonary edema can be caused by the following major pathophysiologic mechanisms. Number 1, imbalance of Starling forces, which could be increased pulmonary capillary pressure, decreased plasma onconic pressure, or increased negative interstitial pressures. Number 2, damage to the alveolar capillary barrier. Number 3, lymphatic obstruction. And number 4, idiopathic or some sort of unknown mechanism. Severe pulmonary edema is a frequent cause of respiratory failure. CPAP increases FRC, increases transpulmonary pressure, improves lung compliance. 10 centimeters of water improves arterial blood oxygenation, and it redistributes extravascular lung water. The application of PEEP to lungs with edema decreases the intra-alveolar fluid volume, increases interstitial lung water, and facilitates the movement of water from the less compliant interstitial spaces where gas exchange occurs to the more compliant interstitial spaces. This redistribution of interstitial water improves oxygenation, lung compliance, and the ventilation perfusion matching when applied in either cardiogenic or non-cardiogenic pulmonary edema. Acute respiratory failure can be treated with CPAP if you catch it early enough. Remember, the patient has to be spontaneously breathing fast enough for the CPAP to work for them. CPAP can overcome inspiratory work imposed by auto-PEEP. It can prevent airway collapse during exhalation and has an effect of splinting the airways. It improves arterial blood gas values and hopefully will help avoid intubation and mechanical ventilation for the patient. CPAP and pulmonary edema, the cost savings. Mass CPAP reduces the need for mechanical ventilation. The mean cost of ventilated episodes is $5,055 with a mean stay of 4.2 days. The mean cost of a CPAP episode is $1,156 with a mean stay of 1.2 days. Not only is there a cost saving, but in critically ill patients that you have to paralyze and intubate, that minute or so of decreased ventilation and then apnea while you do the intubation and tube check may be lethal. In addition, intubated patients can have complications such as great difficulty weaning from the mechanical ventilator. Using CPAP can help avoid mandatory admission into the ICU and reduces the increased morbidity and mortality associated with ventilator-acquired pneumonia and nosocomial infections like MRSA, which are rapidly becoming antibiotic resistant. There are several contraindications of CPAP. Hypercapnic patients may have a reversed respiratory drive and rely on low levels of oxygen to trigger a breath rather than the much more sensitive trigger of carbon dioxide active in normal patients. A patient whose respiratory drive is now sensitive only to low levels of oxygen must not therefore be administered oxygen, as this will knock out the respiratory drive and as a result lead to a reduction of the respiratory rate. CPAP should not be used in patients with an undrained pneumothorax. A bulla within the lungs presents a risk when any type of positive airway pressure is applied to the lungs. A bulla is a large area of the lungs that is broken down to form a hole. Bullae are very brittle and present a risk of bursting, especially at higher values of pressure. This is why we are using 10 centimeters of water as our maximum CPAP. Hypovolemia is low blood volume. Administering CPAP may reduce both blood pressures and cardiac output, especially at higher levels of pressure. Although no true contraindications have been identified in the literature, CPAP should not be administered to patients with unstable facial fractures, excessive facial lacerations, laryngeal trauma, or a recent tracheal or esophageal anastomosis. Patients at risk of vomiting, like those with gastrointestinal bleeding, may also need to be excluded for risk of filling a tight-fitting mask and then aspirating. Some of the common complications associated with CPAP include pressure sores. Since the advent of soft, self-sealing masks, these complications are usually limited to nasal bridge pain and arrhythmia at the site of application. However, these symptoms can be reduced by the prior application of materials such as Granuflex. Another less serious complication of the mask is patient discomfort or intolerance. Gastric distension. The most significant potential complications cited by early critics were aerophagia and aspiration of gastric contents. However, the levels of CPAP used, 10 centimeters of water or less, are usually not associated with gastric distension. If this complication occurs, you can utilize an NG tube. Gastric aspiration related to CPAP via face mask has never been reported in the literature. Pulmonary barotrauma. With mask CPAP, as with any positive pressure airway therapy, the potential for distension and pulmonary barotrauma is always present. However, in an investigation cited by Branson in 1985, only 1 of 196 patients developed evidence of barotrauma, which was a pneumomediastinum, representing a complication rate of 0.5%. The low incidence of barotrauma in these patients may be attributed to the use of spontaneous breathing as the method of ventilatory support. To further minimize this risk, the status of the patient's lung diseases should be considered when prescribing CPAP. Reduced cardiac output. Positive pressure therapy has been associated with a decrease in cardiac output. However, hemodynamic instability in patients treated with the levels of CPAP described in the report was most often due to hypovolemia. In Branson's report, cardiovascular depression did not occur in patients with adequate volume status. Hypoventilation. A potentially lethal complication of mass CPAP is hypoventilation, which may occur with excessive levels of CPAP. Overdistension of normal lung units can increase the ratio of dead space to tidal volume and result in carbon dioxide retention. Hypoventilation may also occur in patients who become lethargic and weak. All patients receiving CPAP therapy should be closely monitored, and if their carbon dioxide retention is identified, intubation and mechanical ventilation should be instituted. Fluid retention. The application of CPAP causes a reduction in urine output secondary to the reduced renal perfusion, redistribution of renal blood flow, and increased antidiuretic hormone secretion. It is often necessary to modify fluid therapy or employ diuretics when applying positive airway pressure if fluid retention and edema are to be avoided. Alternatively, the depression of cardiovascular and renal function, which may occur with CPAP, may be treated successfully with inotropic agents. HCMC EMS protocols indicate the use of CPAP in asthma, COPD, and transmittable respiratory illnesses. In asthma attacks, the protocols do allow you to use CPAP. Remember, the earlier the better, and you can run nebs through the CPAP system. In acute exacerbation of COPD, you are allowed to use CPAP if 2 or more of the following conditions are present: retractions or accessory muscle use, pulmonary edema, a respiratory rate greater than 25 per minute, and a pulse ox of 92% or less, which makes the patient mildly hypoxic. In an outbreak of transmittable respiratory illnesses like SARS, TB, and influenza, you are allowed to use CPAP if 2 or the more following conditions are present: retractions or accessory muscle use, pulmonary edema, a respiratory rate greater than 25 per minute, and a pulse ox of 92% or less, which makes the patient mildly hypoxic. Here is a study of CPAP and acute respiratory failure. In this review and meta-analysis study, they found that pre-hospital use of CPAP in acute respiratory failure reduced the number of patients who were intubated and the number of patient deaths. This study is consistent with a growing body of research that supports the use of CPAP for respiratory distress. While this study was designed to specifically address the value of CPAP for the treatment of acute pulmonary edema, further investigation by the authors discovered that almost 25% did not have acute pulmonary edema as their final hospital diagnosis. The most common underlying conditions misdiagnosed by EMS as pulmonary edema were COPD and pneumonia. We have all been misled by our assessment and heard rails, when in fact the patient had crackles, wheezes, and rhonchi. Another interesting thing about this study is that CPAP patients appear to have been sicker as demonstrated by higher respiratory rates, blood pressures, and subjective complaints of dyspnea. Another difference between these two groups was that the control group was significantly more likely to receive Lasix and morphine, while the CPAP group received significantly greater doses of nitro. Despite these dissimilarities and the inclusion of CPAP use in the patients not in acute pulmonary edema, the CPAP patients still did better in all 3 outcomes compared to the standard therapy. Though not statistically significant due to the low numbers, the patients in the control group who were placed on CPAP after hospitalization also had a lower mortality rate and need for intubation when compared to those who did not receive CPAP at all. CPAP lessens the work of breathing in patients in respiratory distress from all causes and results in fewer intubations and a lower mortality. This has huge ramifications on healthcare costs, as those not intubated are less likely to require ICU admissions. Pre-hospital CPAP reduces the need for intubation and places the patient into a continuum of care that can be continued after admission. The role of Lasix and morphine has been previously evaluated with some studies showing that the inappropriate administration of these drugs to patients who don't have pulmonary edema increases their length of stay and mortality rates. The bottom line? CPAP is for everyone. Rather than go through each of these slides, let us look at the 2006 Hubble study in North Carolina. The study evaluated the cost-effectiveness of pre-hospital CPAP in acute pulmonary edema. Using data from their 2006 publication, they predicted that 4 out of every 1,000 EMS patients would require CPAP for acute pulmonary edema, resulting in 0.75 lives saved. Accounting for the cost of CPAP equipment, including the cost of the CPAP generating system, disposable mask, and tubing for each patient, training of the personnel, and oxygen usage, the authors estimated that the cost benefit of pre-hospital CPAP was $490 per life saved. They also predicted that CPAP would reduce hospitalization costs by $4,075 per year per application. And now, a video on CPAP.
Continuous positive airway pressure, or CPAP, is a method of non-invasive positive pressure ventilation in which positive airway pressure is maintained throughout the respiratory cycle, not just during active ventilation. When performing this skill, start by taking BSI precautions, including at least gloves and goggles. Adjust the oxygen regulator flow to 25 liters per minute. Set the airway pressures on your CPAP to between 3 to 5 centimeters of water, or follow the manufacturer's instructions to ensure an FiO2 of at least 95%. Patients undergoing CPAP must be placed on pulse oximetry and cardiac monitoring to monitor for adverse events. Explain the procedure to your patient and familiarize them with the CPAP face mask or nasal mask. Attach the CPAP face mask connecting line to the CPAP machine. Coach the patient by holding the mask for a few breaths until they get used to the flow of air being directed toward their mouth and or nose.
So the oxygen is going to go through this tubing and into this mask. It's going to help you breathe a lot easier, okay? It's going to feel a lot of pressure into the face. So I just want you to hold that there for a minute. It's a lot of pressure, but just take some nice deep breaths. Feel a little bit better? Okay.
Once the patient is comfortable with the mask, strap the mask in place.
Now I'm just going to secure it to your head.
Continuously reassess the patient.
How do you feel? A little bit better? Okay, I want to increase the pressure just a tad.
Increase the pressure in increments of 2 centimeters of water if the clinical condition has not improved adequately.
You're doing a good job. You're oxygenating your body at 100%.